Let's jump right into this explainer. We're running a rapid-fire review of high-yield surgical cases, specifically targeting those must-know diagnostic scenarios.
Here is our agenda for today. We'll be moving through gastrointestinal pathology, post-op and colorectal surgery, acute abdomen syndromes, and groin hernia management.
All right, Section 1, gastrointestinal pathology cases. Let's look at inflammation and functional disorders. Here's our first patient. A 39-year-old male presents with bloody diarrhea and diffused beefy red mucosa spreading proximally from the rectum. So what's the diagnosis? Are we looking at A, familial polyposis coli, B, Pitch-Jaggers, C, Crohn's disease, D, ulcerative colitis, or E, solitary rectal ulcer? Well, the correct answer here is D, ulcerative colitis. That continuous mucosal inflammation starting right in the rectum is the absolute classic clinical hallmark.
Now, to really lock this in, you've got to contrast that continuous, purely mucosal spread of ulcerative colitis against the transmural, skip lesions you'd see in Crohn's disease. UC literally creates a smooth lead pipe colon because of those lost haustral folds. Crohn's, on the other hand, typically displays a fibrotic string sign narrowing, usually down in the terminal ileum. Moving right along to the next case, a middle-aged man reports unpredictable, severe anal pain lasting less than 5 minutes. Interestingly, his physical exam is completely normal. Diagnosis? Is it A, proctalgia fugax, B, anal fissure, C, SCC, D, hemorrhoids, or E, prostatitis? The answer is A, proctalgia fugax. So what exactly is that? Proctalgia fugax is a functional disorder caused by transient spasms of the pubococcygeus muscle. The key exam pearl to remember is that the pain resolves completely in under 5 minutes. Oh, and here's a rapid exam pearl for you while we're in the GI tract. If you see localized nodular mucosa strictly in the second part of the duodenum, that strongly indicates duodenal lymphoma. Okay, moving on to Section 2, post-op and colorectal surgery, focusing on post-operative complications and oncology. Next question. A 46-year-old female is 3 months post-hysterectomy, and she's spiking a 103-degree fever with a warm, boggy mass palpable anterior to the rectum. What's the diagnosis? A, prolapse, B, hematoma, C, pelvic abscess, D, gossipema, or E, fibroid. The correct answer is C, pelvic abscess. It's absolutely crucial to distinguish this active infectious collection from a gossipoma. A gossipoma is an aseptic, retained surgical sponge that basically acts as a fibrous granuloma. But a boggy mass, combined with a fever, that tells us infected fluid is pooling right in the pouch of Douglas. This requires rapid CT confirmation followed by transrectal drainage. Let's look at another post-op scenario. A 28-year-old female develops a fecalent wound discharge 7 days post-appendectomy. However, she's hemodynamically stable and actually passing normal stool. What's the next step? A, antibiotics alone, B, immediate laparotomy, C, CT scan with contrast, D, discharge, or E, drain placement. The answer is C. You want to use a CT scan with contrast to map out that early enterocutaneous fistula tract. And this brings up a fantastic point about conservative dominance in surgery. You might be surprised to hear this, but up to 70% of low-output enterocutaneous fistulas heal completely on their own without needing an emergent trip back to the operating room, provided there is no distal obstruction. Switching gears to oncology. An anterior resection is a curative option for rectal adenocarcinoma situated at what minimum distance from the anal verge? Options are A, junction line, B, 2 centimeters, C, 3 centimeters, D, 5 centimeters, or E, subcutaneous. The answer is D, 5 centimeters. Here's why that 5 centimeter mark is the magic number. Tumors situated 5 centimeters or more above the verge allow for a low anterior resection, which importantly preserves the anal sphincter. But if the tumor sits under 4 to 5 centimeters, it mandates an abdominal perineal resection, meaning the patient will require a permanent end colostomy. Let's jump into Section 3, acute abdomen syndromes and ED diagnostics. Question. Which property of abdominal pain is clinically most useful for differentiating mechanical intestinal obstruction from diffuse peritonitis? Is it A, radiation, B, speed of onset, C, duration, D, character, or E, nausea? The correct answer is D, the character of the pain. Think about it this way. A restless patient dealing with fluctuating, gripping pain, that's mechanical colic. They literally can't get comfortable. On the flip side, a completely still patient with a silent, rigid abdomen has somatic peritonitis. They don't want to move an inch. And keep in mind, biliary colic is actually a clinical misnomer. The pain doesn't ease off between exacerbations. It plateaus into a constant, unyielding ache. All right, section 4, groin hernias. Let's cover diagnosis and management.
We've got a 49-year-old male presenting with a painful, erythematous, non-reducible groin mass lacking a cough impulse. He is tachycardic and has bilious vomiting. Diagnosis: A, incarcerated, B, irreducible, C, obstructed, D, strangulated, or E, pantaloon. The answer is D, strangulated.
Getting the exact vernacular right here is a real game changer. Incarcerated means the hernia is structurally trapped, but it's non-tender, and the tissue is still viable. Strangulated, however, means the blood supply is compromised, leading straight to ischemic necrosis. And watch out for a Richter's hernia. That's where only the antimesenteric border gets trapped. It can literally strangulate without ever causing a full luminal obstruction. Next case. A 55-year-old male presents with a warm, tender, irreducible right inguinal hernia. What is the absolute most appropriate next step? A, urgent ultrasound. B, elective repair. C, emergent operation. D, incision and drainage. Or E, 48-hour bed rest. The answer is definitely C, emergent operation. In a situation like this, tissue necrosis is imminent, so delaying is fatal. You need to execute rapid preoperative stabilization, get immediate IV fluids going, drop an NG tube for decompression, and administer broad-spectrum antibiotics before transferring to the OR. And whatever you do, never attempt a forceful manual reduction. You risk pushing necrotic bowel right back into the peritoneal cavity, and we definitely do not want that. Our final clinical case. A 45-year-old female complains of a groin bulge. Your examination reveals a smooth swelling, explicitly below and lateral to the pubic tubercle, and there is a positive cough impulse. Diagnosis? Options: A, femoral hernia, B, direct inguinal, C, saphenopharynx, D, lymph node, or E, aneurysm. The correct answer is A, femoral hernia. Anatomical landmarks are everything here. Femoral hernias emerge through the rigid femoral ring, explicitly below and lateral to the pubic tubercle. Because that ring is so rigid, they have incredibly high strangulation rates. Knowing this landmark makes it easy to distinguish them from higher inguinal hernias or from the expansile fluid thrill and venous hum you'd find with a saphenopharynx. So, from understanding the continuous mucosal spread of ulcerative colitis to identifying an aberrant corona mortis in a femoral hernia repair, are your diagnostic instincts ready for the surgical boards?